Welcome back to the deep dive. Today, we are taking on a topic that is, it's just fundamentally critical to the modern healthcare system.
It really is.
We're talking about information risk planning, or IRP. And this is where public trust, massive financial liability, and really complex technology all collide.
That's a great way to put it. When most other sectors talk about data security, they're often thinking about, say, proprietary corporate info or maybe consumer financial data.
Right, credit card numbers.
Exactly. But in healthcare, the stakes are just,
Yeah.
they're profoundly higher. I mean, data protection isn't just about avoiding a fine from a regulator.
It's so much more.
So much more. It means compliance, of course,
Mm-hmm.
but it also means financial viability for the entire organization. And fundamentally, it means patient safety.
And that's the connection we're really going to explore. Our mission for you today is to give you a complete shortcut to being really, truly well-informed on this. We've gone through a deep stack of sources, and we've synthesized an outline of the entire IRP lifecycle. We're going to cover everything from the mandatory regulatory hooks.
Which are non-negotiable.
Absolutely. All the way to the, frankly, staggering costs is what happens when this goes wrong. And then, most importantly, we're going to walk through the rigorous, objective 9-step framework that leading organizations use to actually manage these volatile risks.
And I think we have to start by framing IRP correctly. This is, and it's a really critical distinction, it is not a standalone function that just lives in the IT department somewhere.
Buried in a server room.
Right. IRP is the core, it's the foundational activity of the overall information governance, or IG, program. Think of it like the engine that translates these high-level organizational mandates into practical day-to-day data protection.
And as soon as we talk about healthcare in the U.S., you immediately hit that regulatory wall. This isn't a nice to have. This isn't optional.
Absolutely non-negotiable. For any organization that handles protected health information, risk analysis is a fundamental IPA regulatory requirement.
Okay, so where does that live in the regulations?
Specifically, it's defined under the Administrative Safeguards section of the security rule. It's right there in black and white. So if you don't have a robust, a defensible, and, this is the key word, an ongoing risk analysis program, you simply cannot claim to be HIPAA compliant. Full stop.
That emphasis on ongoing is so vital, and I feel like that's often where organizations really stumble. They treat it like an audit you outsource every couple of years, and then you just check a box.
That's the classic mistake. The mandate, you see, it demands continuous vigilance, and the operational burden it's immense. It requires the regular, constant review of who has access to electronic protected health information, or e-PHI.
Just think about that for a second.
Yeah. Think about the thousands of employees, contractors, third-party vendors, all the systems that touch e-PHI on a daily basis.
It's a huge web.
It is. So monitoring all that access, identifying anomalies, and continuously assessing the potential risks to that e-PHI, that is a massive undertaking. And furthermore, you have to periodically evaluate whether the security measures you already have in place, your firewalls, your training programs, your physical safeguards, are actually effective against new and emerging threats.
So it's not set it and forget it.
Not at all.
Yeah.
If you aren't constantly detecting incidents and adjusting your defenses in real time, the OCR, the Office for Civil Rights, they consider you non-compliant.
Our sources highlighted something that it seems like a really tragic gap right across the entire industry.
What's that?
Many healthcare organizations, they recognize the information risks that are staring them down. They know they have vulnerabilities, but they critically fail to conduct the necessary, proper quantitative assessment and mitigation that the law actually requires.
Yes, that's the gap.
It feels like recognizing a risk is basically useless if you don't quantify the threat and then actually plan against it with a real allocated budget.
That's the exact gap the 9-step framework we're going to discuss is designed to close. And for you, the listener, it's so important to understand the powerful strategic value of a robust IRP. The why should you care question goes so far beyond just avoiding a fine or a lawsuit.
Okay, let's unpack those core benefits then. I mean, obviously you're protecting information assets, which means protecting the organization's reputation. That's massive in a public trust environment like healthcare.
Absolutely.
But here's the link that the research repeatedly brought up, and it's a surprising one. It ties this directly to the core mission of healthcare. A strong IRP actually leads to a reduction in deaths and injuries caused by medical errors.
That is the single most compelling argument you can make to an executive board. Right there. It ties this abstract concept of data governance directly to patient safety outcomes.
Can you walk us through that connection?
Sure. Think about it. If your information systems are properly governed, If they're secure and reliable, maybe they haven't been downed by a ransomware attack, or their data hasn't been corrupted by poor access controls, what happens?
The information is just better, more
Yeah,
trustworthy.
exactly. The likelihood of poor or delayed information contributing to a safety error drops significantly. If a physician can't access a patient's latest medication list because the system is offline due to a failure in IRP, that is direct, tangible risk of a medical error and potential injury.
So data integrity and data availability, which are core IG concepts, they actually become prerequisites for safe patient care. That makes perfect sense when you frame it like that.
It's the whole point.
Yeah.
And beyond the safety aspect, a good IRP creates a strong defense in depth for privacy and security across the entire organization.
Yeah.
It establishes measurable, enforceable privacy requirements.
And it fosters strong accountability.
Strong accountability, which, by the way, is exactly what regulators like the OCR demand to see when they come knocking to do an investigation. They want to know who is responsible.
That structure is absolutely key. So our plan now is straightforward. First, we are going to detail the 3 most serious, common, high-stakes threats that healthcare organizations have to face today. These are the massive risks. Then, we'll spend the majority of our time walking you, step by step, through the rigorous 9-step information risk management lifecycle that provides the necessary defensible framework for a strategic response. Okay, let's unpack this. Before we can dive into that complex 9-step structure, we have to truly get our heads around the massive scale of the threats that are facing healthcare today.
Right.
Because these risks are not theoretical. They are quantifiable, they are happening every day, and they are escalating rapidly.
You can really group the existential threats into, let's say, 3 main categories. First, you've got the catastrophic financial and reputational damage from data breaches.
The big one.
The big one. Second, there's the constant compliance maze of HIPAA violations, and specifically the challenges around third-party partners. And third, the paralyzing instantaneous operational threat that's posed by modern ransomware.
Let's start with risk A data breaches. I mean, these are the ones that grab all the headlines. They are the most serious threat because they compromise patient e-PHI, they fundamentally shatter patient trust.
Which is so hard to win back.
Impossible sometimes. They damage the organization's reputation, and they trigger these catastrophic financial losses. And it's not just in the fines, right? It's remediation, credit monitoring, litigation.
The costs just keep piling up. And the scale of the financial damage is absolutely mind-boggling. Our sources cite the Ponemon Institute, which estimated that healthcare data breaches cost a staggering $6.2 billion.
And that was back in 2016.
In 2016 alone. And this is consistently the most expensive sector for data breaches globally, year after year after year. That figure, it just shows the price tag associated with failing to govern your data correctly. And that cost only grows when you factor in the long-term impact on patient loyalty and future revenue.
To make that abstract number, that $6.2 billion, more concrete, we really need to look at the specific penalties that the OCR has levied.
Good idea.
Because these aren't just costs, they show how regulators penalize negligence and delayed response. They often hit organizations that knew they had a problem but just failed to act on it.
That's a perfect example. Let's take the Metro Community Provider Network in 2017. They were fined $400,000. And it wasn't for some sophisticated zero-day attack. It was for what was essentially just neglected risks.
So what does that mean, neglected risks?
It means they had already identified vulnerabilities in how people were accessing their electronic health record system, but they failed to properly mitigate them. The fine wasn't for the unknown. It was for the failure to act on known issues. That is the literal definition of a governance failure.
Then you have the Presence Health case, also in 2017, a fine of $475,000. And it wasn't just for the breach itself, which exposed about 1,900 individuals.
No, the real sting was in the reason for the fine.
Right. It was specifically for a severely delayed breach notification. They went way past the 60-day limit for reporting the incident.
And that just underscores the point that IRP has to cover not only prevention, but also the rigorous, timely response that's mandated by the breach notification rule. You have to have a plan for when things go wrong.
And the Centene case, again in 2017, showed that sometimes the risk isn't about, sophisticated nation-state hackers. Sometimes it's about the fundamentals of asset management.
I remember this one. They exposed nearly 1 million members. 1 million?
And how?
Because of lost, unencrypted hard drives. Just physical media containing e-PHI and PII that they couldn't account for. If your governance program fails to track where your physical media is, then your IRP has a major, major blind spot.
And for a true sense of the cost when negligence just gets compounded, we have to look at St. Joseph's Health in 2016.
Oof, that's the cautionary tale.
The combined total payout was nearly $9.64 million. That includes a massive $7.5 million in a lawsuit settlement,
Right from the patients.
plus another $2.14 million in OCR fines on top of that. We are talking about costs that fundamentally impact the viability of the entire organization. These aren't trivial survivable costs, they are existential threats.
And that leads us right into risk BHIPA violations and what the research frequently calls the BAA challenge.
The compliance maze.
Exactly, the compliance maze. IPA violations lead to these huge fines, and the regulatory scrutiny can negatively affect future revenue, shareholder value. But what's truly staggering is that so many of the largest violations, they stem from one single critical failure point.
And what is that?
The failure to maintain required business associate agreements, or BAAs.
Can you just briefly define what a BAA is for us?
Sure. A BAA is a legal contract that's mandated between a healthcare provider, they're called the covered entity, and any third-party service provider, the business associate, that creates, receives, maintains, or transmits PHI on the provider's behalf.
So it's the legal armor for your beta when it leaves your building.
That's a great analogy. It's the legal contract designed to ensure patient privacy and PHI protection when the data leaves your direct control. The trap is that organizations consistently, drastically underestimate who exactly qualifies as a business associate.
So it's not just the big EHR vendor or the company that does your billing.
Absolutely not. That's the common misconception. Think about the incredible complexity of modern healthcare operations. Organizations often severely underestimate how widely their e-PHI spreads, and that makes the BAA determination a compliance nightmare.
Give us some examples of these often missed business associates.
Okay, a classic one is a marketing firm that handles patient data for appointment reminders or satisfaction surveys. Or a cloud backup provider that's storing encrypted PHI, a shredding company that handles physical records. Or even certain types of software as a service, SaaS, providers whose operations give them access to the data, even if they don't actively look at it.
And the current technological environment just makes the spread worse, making it almost impossible to track manually.
Precisely. This rapid, uncontrolled spread of e-PHI is driven by several factors. First, the inherent ease of duplicating electronic data. Second, the limited or just insufficient use of sophisticated tools like file analysis and data loss prevention or DLP software.
And the data is everywhere.
It's fragmented across dozens of different departmental systems. And then you add in the widespread, often poorly governed use of mobile devices and bring your own device BYOD policies. That instantly pushes PHI out onto personal-owned equipment that you don't control.
So if a doctor texts a patient appointment detail to a colleague using their personal phone, that's a huge vector of risk.
A huge unmanaged risk. The complexity of this situation became so overwhelming that back in 2016, HHS, the Department of Health and Human Services, they actually had to issue specific software developer guidance to help organizations determine when a BAA was necessary for modern software and cloud services.
Wow. The government had to step in just to clarify the rule.
It shows you just how pervasive and difficult it is to trace every single pathway that e-PHI takes, and it's why your IRP has to include comprehensive vendor management. It's not optional.
That brings us to our third risk, Risk C, the rise of ransomware. This is a truly paralyzing operational threat that hits fast and it hits hard.
Ransomware is, I think, perhaps the most immediate operational danger that a hospital faces today. It instantly encrypts patient files, operational systems, everything. And then it demands payment, usually in cryptocurrency, to restore access.
But the critical regulatory moment here, the one that every executive needs to have burned into their memory, happened in July 2016.
Yes, that was the OCR's formal declaration.
What did they declare?
The Office for Civil Rights formally classified a ransomware attack as a HIPAA breach. The significance of this ruling, you cannot overstate it.
So what does that mean in practice?
It means that if a ransomware attack successfully encrypts your e-PHI, you must immediately adhere to the breach notification rule. You can't just quietly pay the ransom and hope the problem goes away.
No more sweeping it under the rug.
Not at all. You are now facing public disclosure and potentially massive fines, even if you decide to pay the ransom.
And the sheer volume of these attacks makes that compliance burden just enormous.
The statistics are horrifying, and they show that healthcare is disproportionately targeted. According to Verizon's 2017 data, 72%. 72% of all healthcare malware attacks were specifically ransomware.
That is an unbelievable number.
And Symantec noted a 36% increase in healthcare ransomware attacks in 2016 alone. These aren't just random acts of digital vandalism. They are targeted attacks because healthcare organizations have both critical data and a desperate, immediate need to operate. That makes them highly motivated payers.
And of course, 2017 saw the global event that really brought this risk into sharp focus for everyone.
WannaCry.
WannaCry.
Yeah, WannaCry demonstrated the terrifying speed and contagion that's possible when a single vulnerability is exploited on a global scale. It infected over 200,000 systems across 150 countries.
And the impact on healthcare was particularly devastating.
Our sources highlight that in the UK alone, it disabled 48 hospital trusts. 48. It forced them to turn away patients and reschedule thousands of procedures. And crucially, it compromised essential medical devices that were connected to the network.
So it wasn't just files.
No, it wasn't just files that were inaccessible. Essential, life-sustaining medical functions were stopped cold.
When you're facing that kind of paralyzing reality, organizations have to make an impossible choice: pay the ransom or attempt this laborious, often agonizing manual recovery.
And we see the cost of that choice illustrated perfectly by two famous real-world examples that really stand in stark contrast.
Let's hear them.
Okay, let's contrast Hollywood Presbyterian and Erie County Medical Center, or ECMC. In 2017, Hollywood Presbyterian suffered an attack, and they decided, pretty pragmatically, that their #1 priority was restoring patient care immediately.
So they paid.
They paid the ransom. It was a relatively small amount, about $17,000, and they were able to restore their systems quickly.
That's a painful price to pay, and it rewards the criminals, but, it restores functionality. What happened when ECMC refused to pay?
ECMC refused to engage with the criminals at all, and the consequence was, well, it was brutal. They had to operate manually for over 6 weeks.
6 weeks.
6+ weeks. Staff were relying on paper charts, faxes, manual logs for everything. The sources cite their total financial loss. And this is not including any potential regulatory fine. This is just the operational disruption, the lost revenue, and the recovery costs at nearly $10 million.
Wow. That contrast is stunning, from $17,000 to $10 million.
It perfectly illustrates why executives cannot simply rely on intuition or panic in the moment. They need a rigorously calculated expected value for mitigation before the attack ever occurs, because the cost of refusing to pay can be magnitudes higher than the ransom demand itself.
And there's one final piece of this ransomware puzzle, and it's the business model that supports it. It's like the democratization of cybercrime.
You're talking about ransomware as a service, or RAS.
Exactly.
Yeah, hackers are now deploying these RAS kits. These are customizable, easy-to-use attack tools that are just readily available on the dark web, and this dramatically lowers the barrier to entry for criminals.
So you don't have to be a coding genius anymore.
Not at all. Anyone with even a moderate degree of technical savvy can launch a sophisticated, high-impact attack. The developers of the RAS kit, they then simply take a percentage of the ransom proceeds. It turns cybercrime into this low barrier to entry, highly scalable business venture.
And that just exponentially increases the pool of potential attackers and the frequency of attacks.
And the customization of attacks. This is why IRP is constantly fighting a moving target. So this all raises a really essential strategic question. When you're facing risks that are this widespread, this costly, and this easily accessed by criminals, how on earth do organizations structure a response?
Right. It can't just be reactive.
It can't be reactive or ad hoc panic. The answer has to be a rigorous, defensible, structured, 9-step information risk management process. And this forms the core framework of the entire information governance program.
Okay, let's dive into that framework. We should start with the analytical phase, which seems like the necessary homework you have to do before any spending decisions are made. That's steps 1, 2, and 3.
Correct. Step 1 is identify risks, vulnerabilities, and threats. This is the formal, mandated discovery stage. You are actively, formally detecting your internal vulnerabilities.
Like outdated systems or poor staff training.
Exactly. And your external threats, like RAS or sophisticated phishing campaigns, to all of your information assets. This has to be comprehensive. It has to look at technology, at processes, and at people.
And crucially, this identification step, it has to explicitly include an analysis of compliance and legal risks. So federal, state, even multinational laws, which is especially relevant for these large health systems or organizations that handle records crossing state or national borders.
That is the most critical strategic shift of modern IRP. You've hit the
Yeah.
nail on the head. The identification process must define not just the technological threats, but also the mandatory requirements for things like retention periods for patient business records, and the necessary privacy and security obligations for PHI and PII.
And there's a legal point here that is just, it's a hard rule.
It's an ironclad rule. And here is a legal precedence point that every single listener must internalize and repeat to their executive board. Legal requirements always, always override all business needs.
Always. That sounds simple, but I imagine it creates immense internal conflict, doesn't it?
Oh, it does. This is where governance clashes with, say, efficiency or cost cutting. For example, if a state law mandates that obstetric records have to be retained for 25 years,
Right.
no business need, like the IT department arguing for a massive cloud storage cost reduction by deleting old data, can supersede that legal obligation. The law wins. Retention, privacy, and security mandates are the unmovable foundation upon which the entire IRP is built.
Who needs to be at the table in step one to make sure that legal foundation is actually solid?
You absolutely have to have your legal counsel and your records managers or your IG lead deeply embedded from the very start. They are the ones responsible for researching retention laws, for analyzing these complex regulations, and presenting those findings for formal legal interpretation.
And they're looking at things like the Code of Federal Regulations.
The Code of Federal Regulations, state medical board requirements, and they have to ensure compliance with public access laws like the Freedom of Information Act or FOIA, especially in publicly funded systems. Skipping this step means you are building your entire risk profile on quicksand. It will collapse.
Okay, so once that comprehensive list of risks is identified, the legal, the technological, the environmental, we move to step two. Assess potential financial and operational impact.
Right. Now we start to attach a dollar value and a real operational consequence to each of those risks. We are estimating the financial and operational consequences if those adverse events, the breach, the ransomware attack, the massive fine, if they actually materialize within our specific organization.
And the main methodology here seems to be using benchmarking data from other organizations.
Yes, comparing your organization to peer organizations that have already suffered those exact losses is essential. Analyzing cost data from comparable organizations allows you to predict potential financial losses and to estimate the extent of operational disruption.
So you're looking at things like the cost of maybe data breaches elsewhere.
The cost per record lost, ransomware attack recovery costs, 8AA non-compliance fines at organizations of a similar size and scope. You're learning from their misfortune, essentially.
But as we mentioned earlier, you can't just use those raw numbers directly. If a massive multi-state health system gets fined $10 million, a small regional provider can't just plug that number into their plan.
Absolutely. And that's where normalization comes in. This is a crucial step that differentiates a serious IRP from what is basically just a guesswork exercise. The financial impact estimates must be adjusted based on the size of your specific organization.
How do you do that?
You need to calculate ratios. So, loss per patient record, loss per employee, or maybe loss as a percentage of your annual operating budget, and then you apply that factor to your specific scale.
So normalization is where you incorporate all of your own unique variables.
Exactly. And furthermore, those estimates need to be adjusted to reflect your unique competitive environment, your specific regulatory environment, which varies significantly from state to state, and even the current economic conditions. A fine that was levied during a period of high regulatory vigilance might be higher than one from a slower period.
So normalization provides a tailored, realistic estimate of loss that the board can actually trust.
Precisely.
And that sophisticated estimate leads us directly to the heart of the matter. Step 3. Determine probability and prioritize action. This is the analytical core of IRP.
This is where we assign a percentage likelihood to each of those identified adverse risk events. And it's necessary because, as we know, not all risks are equal. A catastrophic multi-million-dollar event might have a very low probability of occurring, while a smaller, say, $50,000 incident might be highly likely.
Okay, so we have the cost, which is the impact, and we have the likelihood, the probability. How do we combine those two to make a rational decision about where to spend our finite resources?
That is the power of the expected value calculation, or EV. EV is the key analytical tool that is used to move the budget discussion past subjective fear and emotion and into objective, defensible allocation of money.
And the formula is simple.
Elegantly simple. Expected value equals financial impact times probability.
Let's run those numbers again, just to show why this is such a game changer for executive decisions.
Okay, let's imagine two risks. Risk A is a massive potential breach with a $5 million financial impact, but it only has a 5% likelihood of occurring in any given year.
So 5 million times 5%, that's an expected value of $250,000.
Correct. Now, risk B is a less catastrophic data loss event. Let's say it has a $2 million impact, but with a much higher probability of happening, say, 10%.
2 million times 10%. That's
Yeah.
an EV of $200,000.
Right.
So even though risk A would be a much bigger, more terrifying event if it happened, its higher expected value means that analytically you should spend money to mitigate risk A first. It provides the better return on investment for risk reduction.
Precisely. Higher EV risks must be addressed first. This calculation provides hard, objective budget decision support for executives, and it proves the value of the information governance program. It allows the IG team to walk into the boardroom and say, we need $150,000 to mitigate risk A, because doing so avoids an anticipated annual loss of $250,000. That is a conversation executives understand and respect.
This whole prioritization effort is foundational to what's called enterprise risk management, or ERM, across the entire business, right?
Yes. It generates the formal risk profile. The risk profile is the foundation of ERM. It's the document that helps executives logically link all their identified information risks back to the organization's core business objectives. And it allows for structured, defensible resource allocation against all enterprise threats, not just IT failures.
And this profile, it needs to be executive ready. It can't be a 1,000-page technical document full of jargon.
Absolutely not. It must be clear, it must be simplified, and it must be tailored for decision makers. The typical time horizon for these profiles is about 3 to 5 years, so it establishes a long-term roadmap.
And how often does it need to be updated?
They have to be updated at least annually, at a minimum. Or, for highly volatile industries like healthcare, given the constant shift in the threat landscape, probably quarterly.
What are the common methodologies used to visualize this complex profile so an executive can understand it quickly?
You typically see 3 standard approaches. The simple top 10 risk list, which is easy to read but it lacks a lot of nuance. Then there's the risk map.
And what's that?
That's a 2-dimensional grid that plots likelihood on, say, the x-axis from 1 to 5, against impact on the y-axis, also 1 to 5. This is great for quick analysis, but perhaps the most powerful tool for immediate decision-making is the heat map.
The color-coded severity map. Why is that one so preferred in the executive suite?
Because it provides instant, non-technical prioritization. It's visual. Risks that are categorized as red, high likelihood, high impact, that signals to leadership exactly where immediate, large-scale action is required. Yellow zones are risks that need monitoring and maybe mitigation, and green zones are acceptable risks. It visually justifies why the IT budget needs to be spent on that specific red area first.
But to get these maps and profiles, the data gathering process must be incredibly rigorous and cross-functional. This can't just be IT filling out a questionnaire in a silo.
Oh no, it requires a deep, deep dive into the organization's actual processes. It might start with surveys, but it has to quickly move to direct, deep interviews across all departments. You start with the executives and the risk professionals, but then you have to interview a wide cross-section. 20 to 40 interviews may be required.
And you want to do this quickly.
Ideally, you complete them within a tight time frame, maybe 1 to 3 weeks, to capture a current, accurate snapshot of the organization.
And the sources really emphasize using a 2-person team for these interviews. Why is that structure so effective?
Because deep dive interview work is mentally intensive. One person, the interviewer, can focus entirely on engaging the subject, listening actively, asking good follow-up questions, and maintaining rapport. The second person acts as the dedicated note-taker and observer.
And what are they looking for?
They're ensuring the accurate capture of crucial, often very nuanced details and even nonverbal cues that might indicate process friction or a policy workaround that the person won't admit to out loud.
What exactly are they trying to uncover in those interviews beyond just, generic complaints?
They're exploring very specific, high-risk operational areas. This includes policies around EHR and e-PHI access, how email retention is actually handled versus what the policy says, the formal legal hold process, what happens when litigation starts, and data deletion policies.
And critically, they look for corporate culture insights.
Yes, they actively explore workarounds. When processes are too difficult or cumbersome, people create shortcuts and workarounds. And those workarounds are often the true source of systemic risk and vulnerability in an organization.
And finally, Step 3 requires this continuous tracking of major external events that might invalidate the current risk profile.
Yes. The list of risks that you generate isn't static. It has to continuously account for external factors. Things like major lawsuits against your competitors, significant regulatory changes like new HIPAA rules or state privacy laws, shifts in business ownership, or even governmental leadership changes that might influence enforcement priorities.
So you're constantly scanning the horizon.
You have to be. These external developments must be continuously tracked and factored into your risk profile updates. Finally, all the risks you've identified are grouped into clusters: natural disaster, regulatory, technological, and that just helps stakeholders better understand and manage the whole portfolio of risks holistically.
Okay, so we've established the enormous risks, and we've completed all the deep analytical homework of quantifying them and setting priorities using expected value.
The heavy lifting of the analysis phase.
Exactly. Now we move into the execution phase. This is the strategic action, the policy creation, and the accountability loop. Let's start with step 4. Create high-level strategic plans.
This is the essential transition from analysis to action. The IG Steering Committee takes that prioritized list of red zone risks and develops concrete, high-level countermeasures. And these are designed to reduce both the likelihood of the risk occurring and the impact if it does occur. The result of this is the formal Information Risk Mitigation Plan.
And this plan is the blueprint for action. What are the key components that ensure a mitigation plan is actually robust and executable, not just a document that sits on a shelf?
It has to be concrete, and it has to be actionable. It has to move beyond vague statements like improve security. That means defining very clear roles and responsibilities. It means establishing those measurable risk reduction metrics we'll talk about, setting clearly stated milestones, and providing a detailed, realistic implementation timetable.
So it's a real project plan.
It's a real project plan. The plan should also explore multiple mitigation options for each major risk. For instance, the risk of a breach might be mitigated by new technology or by better training, or a combination of both. You need to evaluate the options.
And what are we seeing as the common major risk mitigation tasks in this high-risk healthcare environment today?
Given the reliance on human factors and decentralized data, some really common tasks include developing a robust, mandatory, and consistent security awareness training program that is continuously updated.
Not just once a year.
Not just once a year. Also, the acquisition and very careful implementation of new IT security tools like better DLP or advanced monitoring. And, perhaps most crucially, the clear assignment and enforcement of individual accountability across the entire organization for executing those policies.
That focus on tracking execution is so vital. Our sources mentioned a specific visual tool that helps track this progress.
Yes, the risk mitigation table. It's a great tool that provides an easy-to-read visual. It tracks the top risks, their initial potential impact, the specific mitigation actions being taken against them, the person or team who is responsible, and the current progress status. It keeps the whole execution process transparent and visible to the executives who hold the purse strings.
Okay, moving from that strategic blueprint, we arrive at step 5. Convert strategic plans into specific policies.
This is the crucial translation step that ensures organizational consistency. High-level strategic plans are utterly useless if they don't change daily operational behavior.
Right. It has to impact the frontline worker.
Exactly. Therefore, the plans must be converted into formal, daily operational policies and embedded information governance practices for consistency. If the strategic plan says mobile data must be secure, the policy has to say all mobile devices accessing e-PHI must use organization-mandated encryption and passcode requirements. It has to be specific.
Where are healthcare organizations focusing their policy review efforts right now, given the risk vectors we discussed earlier?
The focus is overwhelmingly on communication and mobility tools that handle PHI and PII, because these are so often the weakest links in the chain. This requires a thorough policy review for email use, text messaging protocols, instant messaging, and social media use. Staff need to know exactly what they can and cannot communicate via these channels.
And the device policies themselves.
Oh, absolutely. They have to update policies for mobile devices and BYOD, cloud computing use agreements, and internal systems like SharePoint governance or any other collaboration platforms. The rule is simple. If PHI is involved, the policy must be explicit, easy to follow, enforced consistently, and regularly audited.
That attention to detail leads us directly to the measurement phase. Step 6. Determine metrics to measure risk reduction.
And what's really fascinating here is that metrics are absolutely essential because risk reduction is often completely invisible. Well, if you spend $1 million and you successfully prevent a breach from happening, there's no visible event. There's no celebration, no ribbon cutting, nothing happened. So metrics are the only objective way to track real progress, to detect internal weaknesses before they cause a failure, and, most importantly, to justify the continued, often expensive investment in the IG program to the executive suite.
So these metrics, they have to be objective, quantitative, and tailored to the organization's specific business objectives, not just vague goals like be more secure.
Precisely. They must focus on measurable outcomes that are linked directly to risk or cost reduction. We aren't measuring activity, like number of training sessions held. We are measuring impact.
Can you give us some specific measurable metric examples that listeners could actually use to guide their own IRP efforts?
Sure, you should define metrics that focus on both quality of care and security outcomes. For quality, a good metric could be reduce medical errors caused by poor or delayed information by 10% over the previous fiscal year.
Okay, that's a great one. What about on the security side?
In terms of security, reduce data loss from stolen or misplaced laptops by 50% year over year. Or reduce the number of successful hacker intrusions that are identified by 25%. Compliance teams often focus on cost reduction metrics like reduce e-discovery document review costs by 25% by implementing better data deletion policies.
And what about technical metrics that show concrete implementation progress, things that are a little more granular?
Those are also vital for project management. For example, successfully implement full disk encryption software for 50 specified high-risk users during this fiscal year. These are quantitative, time-bound goals that clearly demonstrate the successful execution of your mitigation plan. They transform abstract planning into documented progress.
And that execution relies entirely on accountability, which brings us to step 7, assign accountability.
Mitigation plans fail without clear, formal accountability. It's as simple as that. Specific individuals or entire teams must be formally assigned responsibility, not just for the initial execution of the new policy or tool, but for the ongoing maintenance and monitoring of those controls over time.
And you mentioned this assignment has to be strategic. It's not just about picking someone.
No, it must be based on professional expertise and functional responsibility. It is completely illogical to assign technical security implementation to a medical records manager, just as it's illogical to assign policy compliance and training development solely to an IT technician.
So you need the subject matter experts.
Individuals with subject matter expertise are simply best suited to manage risks in their specific area of operation. The IG Steering Committee is the body responsible for ensuring this clear assignment of duties.
Our sources provided a great practical example of why this collaboration and assigned accountability is so necessary for success.
The PHI encryption rollout example, it's a perfect one. If the IRP mandates encrypted communication between staff and external partners, the successful rollout requires very structured collaboration.
So who's involved?
The HIM manager, the health information manager, who understands the legal and compliance needs as well as the data flows, and the IT manager, who handles the technical implementation and maintenance. They must collaborate. Their joint responsibilities would include project management, rolling out the solution, developing the mandatory training programs for all staff, and creating an internal communications plan to enforce the new requirement.
With accountability defined, we finally hit step 8, execute the risk mitigation plan. This is the project management phase where the rubber really meets the road.
And it requires proven program management tools. Whether you're using Agile or Waterfall, the standards are proven for a reason. But the execution may also require additional specialized tools like collaboration software, knowledge management systems, and centralized document repositories.
But regardless of the technical tools you use,
Regardless of any of that, the single most important element of program management is clear, constant, and regular communication.
why does communication rise above everything else here in the execution phase?
Because executing a large-scale IRP involves changing behavior across the entire organization. Communication is essential to keep the team motivated, to track progress transparently, to manage expectations, and most critically, to identify emerging problems and challenges early before they can derail the entire mitigation effort. All IG team members and the executives who support them must be continuously informed of progress in the risk reduction efforts.
And finally, we close the loop with step 9, audit, review, and adjust. This is the continuous improvement mechanism that ensures IRP is truly ongoing, as we said at the start.
Exactly. Auditing, which can be conducted internally or by external consultants, evaluates your progress against the metrics you established back in Step 6. The audit results provide objective input for fine-tuning the IG program, for adjusting your priorities, and for guiding continuous improvement.
And the mindset here is key.
It's absolutely crucial that the organization adopts the mindset that the audit is not punitive, is not a witch hunt. It's a tool to strengthen the IG program, to justify the resources you've been given, and to improve performance over time.
So let's just summarize the entire process by recapping the 5 basic assessment steps that form the foundation of this ongoing audit loop.
Okay, 1. Identify your risks, focusing specifically on the major information-related risks that came from your risk profile.
2. Determine potential impact.
Right. Estimate the economic or operational business impact through that normalization and benchmarking process.
3. Evaluate risk levels and probabilities.
Yes, using the expected value calculation. And then you recommend specific action, whether that's new procedures, new processes, or new IT investments.
4. Create a formal report and implement the plan.
Create a formal, executive-ready report with those recommendations, and then implement the necessary mitigation plans.
And finally, 5. Review periodically.
Annually or semi-annually, depending on the volatility and risk level of your organization, to ensure that continuous improvement actually happens.
Wow. We have covered some massive ground today, navigating this incredibly high-risk world of healthcare data, from the threat landscape all the way through to the execution roadmap.
It's a lot to take in. The synthesis is pretty clear, though. Healthcare organizations are facing quantifiable, massive risks. These are driven by data breaches, paralyzing ransomware attacks, and these complex IPA compliance mandates, especially regarding the management of business associate agreements.
And the financial and operational costs of failure are just simply too high to ignore.
They're existential, as you said.
And the necessary solution is not reactive. It has to be a proactive, structured, continuous 9-step process.
And that process has to be centered around the objective, expected value calculation impact, multiplied by probability. That serves as the objective basis for strategic executive budget decisions, and it's the foundation of the entire enterprise risk profile.
And we should repeat that absolute strategic priority we established in Step 1.
Yes. When you're identifying information risks and requirements, legal requirements always, without any exception, take priority over all other business considerations. You have to build your governance program around your minimum legal retention, privacy, and security obligations first.
So if we connect all of this to the bigger picture, we need to think about future volatility. We discussed how the rise of ransomware as a service, the RAIS kits, is continuously lowering the technological barrier to entry for high-impact cybercrime.
Right. It makes it easier for everyone to be a bad guy.
Exactly. So given that ease of access, that customization, and the resulting increase in the sheer volume of potential bad actors, how should an organization's risk profile, which is typically set for a 3 to 5 year horizon, how should that shift?
That's the critical uncertainty, isn't it? It suggests that if the threat landscape is changing this fast, even the traditional annual review cycle for your risk profile might be too slow to capture these emerging risks. Volatility is the new norm. IRP, I think, has to move toward near continuous assessment and adaptation.
Because the game is just moving that much faster.
The game is moving faster, because if the technological barrier for launching a $10 million attack is effectively 0, your defense needs to be ready faster than ever before.
Something for you, the learner, to mull over as you build out your next 3 to 5 year risk horizon. That's all the time we have for this deep dive.